All right, and I probably will write a little bit on this one. So next we'll talk about postpartum hemorrhage. So once again, postpartum hemorrhage can be like, if we talk about every nuanced detail, that can be an hour-long talk, but this is for the sake of review. We'll try and hit some quick hitter things. And then I also have, I mean, if you want to keep taking notes, that's great. I also have all my notes from the OSCE review that I'm happy to send out to you to study as well. So, but postpartum hemorrhage, just like shoulder dystocia, like Dr. Williams mentioned, number one, you got to always think about draining the bladder, drain the bladder, drain the bladder.
Even if you drained it before the shoulder dystocia, and then now you're bleeding.
Yeah.
Sometimes I start diuresing a lot.
Yeah. So, like she said, even if it has been not very long before that, would still drain the bladder. Okay. So then the big thing for postpartum hemorrhage is identifying why the patient's hemorrhaging, and then fix that underlying problem, right? So for our etiologies, what is our mnemonic that we remember for our etiologies? So yeah, we have our 4 T's. So most commonly, tone, tissue, trauma or tear, yeah, and trauma. Alrighty, so tone, this is like far and away the most common. 70% of your postpartum hemorrhages are going to be due to acne. So what do we do for this? So let's start from the beginning. Yep. So what did you say, Corbett? I said massage. Yeah, so that's massage is part of what? Active management of third stage of labor. Perfect. So what is included in the active management of third stage of labor? Say it again. So gentle traction on the cord. Cord traction. Pitocin. And bundle massage. Yeah. Quick offshoot. Most women have an IV. If they don't have an IV, how much pain are you going to give them?
10 each butt.
So for MAG, you give them 5 grams each butt if they're having an eclamptic seizure. But for PIT, you just do 10 units in the shoulder. Fine. So, all right. So we started with our active management third stage of labor. That's after we have drained the bladder. Now, what are our meds that we can give for tone?
One other thing on the tone. So talk about the difference between MEU, and then like you did final massage.
Oh, sure.
Versus...
Yeah. So, and we'll talk about. Oh, nice. I've not seen this model before. What is this?
It goes to the pelvis. So it's okay. Yeah. This is the uterus.
But this is the cervix.
This is the cervix. Yeah.
Okay.
Yeah. So I mean, so when you're doing tone, sometimes the attending is doing things internal that you're not aware exactly. You think you know what they're doing, but you could be wrong. And so we do. So you did active management, and then you did the final massage, and then I guess I kind of jumped ahead because I stepped out, but so you. So if you don't have good tone, you actually could potentially do an MEU and make sure that there's no tissue remaining. And then so if the tissue was then out and then you're doing massage internally and externally, you don't keep your hand inside the uterus. You actually have it behind the cervix, and then you have your hand outside here. So you're compressing it. So it's the same thing as when you're in the OR. And maybe you've noticed that when the attending, the attending say that it's really bleeding, the attending will pull up on the uterus, and then it makes the bleeding less. And so it's the same, you're trying to do the same thing, but you have your fist in here and you're pressing it like that.
That makes sense. So MEU, you're obviously going through the cervix, inside the uterus, trying to sweep out any remaining tissue. And then when you are doing the massage from both sides, like she mentioned, you're kind of going posteriorly with one.
So the bimanual massage.
And then you're just kind of trying to do manual compression. Does that difference make sense? Sweet. Okay. Sounds good. And then the meds that we have. So we already started with PIT, side effect, okay, how much? 800 micrograms rectally. All right, what else? TXA, how much? 1 gram, how? IV is TXA, perfect. Don't give that if they have weird bleeding or clotting disorders, or if they are colorblind. Other meds? Methergin, how much?
Okay.
0.2 milligrams IM. And lastly, Hemabate. How much? 0.25 milligrams. This is also IM. When would we not give Methergin? Any sort of hypertensive disorder? When would we not give Hemabate? They have asthma. All righty. Questions about that? Sweet. And then, yeah, we would, other things you can do for tone are like the bimanual massage, like Dr. Williams mentioned. So. And then, so that's about 70% of your postpartum hemorrhage. About 20% is going to be due to tissue. So you retained products. So like, you had trailing membranes, or didn't have trailing membranes, but they still have just a part of the placenta still in there. Like, there's no way to fix that other than going in there and getting it. Usually, and that you do that by name. Yeah.
Or same theory is
Basically,
clots.
we just
That's
think
what postpartum hemorrhage. You see on postpartum
Oh.
before.
Mhm.
It's a bunch of clots in the lower uterine segment that actually time me down. So I think we always end up sensitive. I think the tissue, but it also is clot.
Yeah. So for those on the recording, Dr. Neal just mentioned that not just placenta, but clot burden as well. And honestly, I feel like that's even at delivery, that can sometimes be a huge deal. You just have a clot in that lower uterine segment. You don't even have to do you should do a full MEU, but you're not necessarily getting stuff out of the fundus of the uterus, but just out of that lower uterine segment. And then once that clot is gone, so other additions. If they're unblocked, make sure you give them some pain medicine. So trauma, so this could be cervical laceration, unlikely perineal laceration causing a huge hemorrhage, but it can. The last delivery we had, that's what the hemorrhage is from. And then you got to fix that. And then thrombin is if they're in DIC or if they have von Willebrand disease. Those could be contributing. So what's really important for postpartum hemorrhage, I was talking to Dr. Wolf last July, asking him, what do you wish that we were better at? His number one thing was calling out postpartum hemorrhage early. So not waiting for things to get really bad before we say, oh, hey, we need to start doing stuff. Because the worst thing that you do, now we don't need to give every woman all of these things, but it's in his eyes, better safe than sorry on that.
And there is a movement towards giving the TXA. We get that a lot now. So if you have a hemoglobin starting out that's 10 or less, we really should be giving TXA. And that's why we've also been more aggressive treating anemia in the outpatient setting. And I'm really proud of us. I think we're doing a lot better job.
Or even if you have someone who is a grand multip and on PIT and is, why not just give her a side attack?
Yeah. Yeah. Just be very pessimistic. This is what kills women.
And that's the morbidity and mortality, I don't know what word I'm looking for. Yeah. But the emails that we get that talk about our morbidity, one of the things is having to give blood transfusions after delivery. So that's one of the ways that we can
they're tracking that.
Get better at that. So so these are some specifics. Big picture wise though, or with postpartum hemorrhage, it's really important to have the big picture in mind and know okay, am I treating this patient like an H&P patient where I have a little bit of time to ask them questions, or is this like a ABCs where I got to be worried about airway breathing and circulation, right? So if you have a lady that's hemorrhaging a lot, this is really important for your OSCE to know like what you do in that situation beyond these, but like just like general steps that you're going to do to take care of. So what are you going to do if you have, I mean, sure, let's say it's on the OB floor, but if you have somebody come in the ER, major hemorrhage, what are some things that they need? So yeah, so 2 large bore IVs. So it can't be like, oh yeah, they got one in their arm and one in their hand. They need 2 large bore IVs. What else? Yeah, type and cross. And maybe blood. What else? Yeah, volume resuscitation. Yep, find the cause, find and treat the cause. And then also for the sake of real life and for your OSCE, don't forget frequent vitals, because you need to know whether her blood pressure has been 120 this whole time and now it's 80 over 60, or whether it's been, or whether she's gone from 120 to 110. You know? Does that make sense? Let's make sure. Perfect. I think that is it for postpartum hemorrhage. Any additions, Dr. Neal? Okay, yeah. But this last part here, really important for your OSCE. I mean, and for your life, but
yeah, I guess the other thing I would say is similar to when you guys saw it also, a lot of places we aren't doing it nearly as much here as we probably should be, that are weighing everything afterwards, because it's almost always a bit underestimate, right? And so depending on where you're going, you might see a lot more vigorous of weighing everything.
Yeah.
Great. I can look this up these things probably, but it's just a one time with all of those bits, right? Or I don't know how quickly.
So Cytotec is a one-time. TXA, the IV, I guess technically is a one-time, though you can't do oral TXA, TID after that. Methergin, you can give Q4 to 6 hours, and then Hemabate, you can actually give every 15 minutes up to 8 doses, though I've never seen that given more than once. So the thing that I've seen the most is PO Methergin Q6 for the next 24 hours.
Or longer.
Or longer. You have seen IV TXA reviews? Okay. I don't know what the
duration is, but like for a couple of uterine artery embolization patients that we've had, they've gotten 2 doses of TXA, like one before and then one after.
Gotcha. Yeah.
But I don't know what the
Yeah. And I suppose for completeness sake for this video also, I don't think we'd get to that point on the OSCE, maybe so. But like advanced stuff, then if you've made it through all this, then you're talking about a Bakri or Jada now. And then hopefully not a B Lynch suture, uterine artery embolization, and then
if that's available where you're practicing.
if that's available where you're practicing, or hopefully not hysterectomy. So those, I don't think we go into that for the OSCE. It's just this, but just for the sake of completeness.
And in our practice of when we're giving a third med, we're supposed to have the laborist involved and not already involved.
If you, Dr. Craddock said, like, if you're giving a second med, then you should call them, which I think is totally appropriate. So.
Are we gonna go over, like, for the OSCE, do we need to know which pads weigh how much?
Oh, no.
Okay. Okay, the
Yeah.
would be like, how much blood?
That was for also.
Yeah, that was awful.
I think I would have won farthest off if you totaled how far off we were on all that stuff for also. But alrighty, I think we'll call it quits on postpartum hemorrhage.